Welcome back, everybody. I hope you had a good break. I'm Don Berwick, pediatrician and President Emeritus and Senior Fellow at the Institute for Healthcare Improvement, and I have the privilege to chair this wonderful committee. We're going to hear in a minute a panel to build on the first two panels now to focus on family impacts from traumatic brain injury and family engagement in TBI care. Before that, I want to reinforce one message about these open meetings. The process of the sessions we're having now are very dynamic and interactive, as you saw from the first two panels. The committee members are asking hard and important questions, but I want to caution you, these are not intended to reflect conclusions reached by the panel members or by the panel itself. Those conclusions do not exist yet. We are going to be deliberating and producing a report downstream. So we don't want anyone to misinterpret comments or questions made by committee members. That said, I got very excited by this morning's panels. The first panels, they set a pretty high bar, but I'm sure we'll meet that bar. And I'll turn this over now to my colleague, Helene Moriarty. Helene is a member of the committee. She's the Diane and Robert Moritz Jr. Endowed Chair in Nursing Research at Villanova University and nurse scientist at the Corporal Michael J. Crescenz VA Medical Center. Helene, thanks. Take it away. You are on mute, Helene.
Thank you. I am delighted to moderate this session and to welcome our panelists. In my nurse scientist role at the VA in Philadelphia, I have been very fortunate to learn from the insights, the stories, the experiences of veterans with TBI and their family members. And over the last 10 years or so, I have been developing and evaluating an in-home rehab intervention for veterans and civilians with TBI and their families. So from my interactions with many veterans and families, I hear loud and clear that TBI is a family affair, and it may have a profound impact on persons with TBI as well as their families. Our panel today will describe the family impact of TBI from both personal and professional perspectives. They will also address family engagement in TBI rehab care along the rehab journey, their perspectives on engagements of families in rehab, what is happening now, what concerns they might have, and their hopes and vision for this in the future. And I remember one of the early panelists said very clearly, he said, the love and support of family was the most important positive aspect of my care, which I think highlights the key role that families may play in TBI care. So I would like to briefly introduce our panelists first. Susan Connors is President and Chief Executive Officer of the Brain Injury Association of America, and she's also prior Executive Director of the National Association of State Head Injury Administrators. Anjul Sanders is Associate Professor in the Department of Physical Medicine and Rehab at Baylor College of Medicine, and she's also Director of the Division of Clinical Neuropsychology and Rehabilitation Psychology. Elizabeth Rotenberry, goes by Liz, is the Elizabeth Dole Foundation Fellows Program Manager, and she's also a caregiver to a wounded military veteran. Kelly Williams-Gary is an assistant professor in the Department of Occupational Therapy at Virginia Commonwealth University and a member of the leadership team for the Culture, Race, and Health Core in the VCU Institute on Inclusion, Inquiry, and Innovation. And she also sustained a severe TBI about 28 years ago. And so we will ask each panelist to speak about 5 minutes, and then we will have an opportunity for discussion. And so I'd like Susan to begin, please.
Thanks very much. I'm Susan Connors. I'm the president and CEO of the Brain Injury Association. We're the nation's oldest and largest advocacy organization. BIAA was established about 40 years ago. I've only been involved for 25. In my opinion, brain injury care has improved during the time that I've been involved, but access to care, especially access to post-acute rehabilitation and community-based services and supports, has not improved. There are several reasons for this, but I believe payers are the main culprit. In my opinion, rehabilitation is the single most effective treatment to stop, slow, or reverse the disease processes caused by brain injury. Along with counseling and medications, rehab helps people maximize health, function, independence, and community participation. And even though rehabilitation is one of 10 essential health benefits in the Affordable Care Act, America's health plans limit OT, PT, and speech to 20 or 30 visits per year. Anyone who has experienced a moderate or severe brain injury, or even a complex or complicated mild injury, knows that this is insufficient. And so first point is, wouldn't it be great if payers were required to cover comprehensive rehabilitation of sufficient scope, duration, and intensity? A second challenge is a lack of information and training for families. I think this was covered earlier, but just about the time you figure out what a physiatrist is, your loved one is discharged. And like the song says, you don't have to go home, but you can't stay here. Rather than explaining what an IRF, SNF, or LTAC is, families are handed a list of facilities, sometimes with wrong numbers or wrong websites. Wouldn't it be great if case managers and discharge planners were paid based on patient and family satisfaction? By the way, discharge sicker and quicker and discharge to the couch are not trite expressions. They are the lived experiences of millions of patients, including those with so-called mild injuries who are released from the ER. Wouldn't it be great if discharge papers included an 800 number for contact information of people who are knowledgeable and caring specialists in brain injury who could provide the right information and resources? Once patients and families are home, specialized services and supports are limited. Kansas and 15 other states have Medicaid waivers, but not all of them are TBI specific, and most of them have long waiting lists. 21 states have trust funds that provide a range of services and supports, but eligibility is limited. Caps are included in spending, and sometimes the trust funds are raided when state governments run short of funds. Auto no fault, as was mentioned earlier, works great in some states and poorly in others. All states have vocational rehab programs, but few have specialty case managers. Ditto for mental health system, criminal injustice, juvenile justice, domestic violence, etc. Wouldn't it be great if state governments had adequate resources to train personnel and existing programs to better serve individuals with brain injury? Congress could start by appropriating enough money for every state to participate in the TBI Act state grant program. There are some things that are working well: better access to COG rehab. Telemedicine has been successful during the pandemic. But wouldn't it be great if telemedicine were delivered at the patient's option, not just when there's a pandemic and not just for provider convenience? As for who is underserved, seniors are often misdiagnosed as having dementia and are deemed, quote, not candidates for intensive rehab. Individuals with mild injuries because they're walking and talking and therefore are viewed as not needing care. And finally, anyone who has acquired a brain injury due to anoxia, hypoxia, which covers millions of people who overdose, those with long COVID, and myriad other causes. The non-traumatic brain injury community is where the TBI community was 25 years ago. Wouldn't it be great if we welcomed them into our club? Thank you.
Thank you, Susan. Let's now hear from Kelly Williams-Gray. You are muted, Kelly.
Hello, everyone. Thank you for the invitation to come and speak today. I am coming from a lot of different perspectives. In 1990, I sustained a severe traumatic brain injury from a car accident when I was finishing up my sophomore year in college. And it manifested in many physical, cognitive, and emotional injuries that followed me for many years. The physical got a lot better very quickly in the hospital, but I still continued to have residual cognitive and emotional deficits for many years, and still do to this very day. After my injury, I pretty much, after spending about 4 months in the hospital, and back then in 1990, it was definitely, you could spend much, much more time in the hospital and get the care that you needed. However, once I finished and I had a little bit of outpatient care, I was discharged home to my parents without much care after that. And my parents had no idea really about what to do with me. And I had no idea. And I had a lack of insight, and I was very impulsive. So all the ideas that I had was to return back to school where I enjoyed and where my goals were set. I was in the military, and I wanted to go back to school and finish up my military training and become a commissioned officer in the U.S. Army full-time once I graduated. So that was my goal. And my parents did not know what to do. So I actually threatened my parents and tried to go back to school on my own, and they wouldn't let me. But then they allowed me to go to kind of see and keep a close eye on me to kind of see what I could do. I totally failed at everything and came back home and tried to start my life over. I did that after some time and ended up finishing my degree while I was at home, still living at home, and changed my major, was medically discharged from the military, but changed my major to occupational therapy. And then spent a lot more time at home with my family until I was able to go back out on my own. After that, I received 2 masters at Columbia University. I moved to New York on my own, received 2 masters, and then ended up living my life and getting a PhD later on at VCU. And now all of my work is devoted to working with individuals that have brain injury. My research is devoted to brain injury and other disabling conditions, more so racial and ethnic minorities, and also family and caregivers, and how to make their lives better after brain injury. My gripe with brain injury is that parents just really don't know what to do. There's so many challenges that they're going through. There's so many things that they have to deal with. And it's a dilemma of just so many things that a lot of times just helping that person with a brain injury is just something that's totally foreign to them. And as much as people can tell you what to do, as much as professionals can give you information, particularly when you're dealing with so many different things, especially when it's traumatic and it's so unexpected, that information just is not readily available to them, or they might not even be able to find it. So I've seen in Virginia what I've not seen in a lot of different areas. There's places like brain injury clubhouses that give family members a little bit of a respite and allow those people that are survivors to be able to go back to a productive lifestyle. Now, that's something that's not common in a lot of other places. As a matter of fact, about 6 of them, maybe 6 to 8 in the whole nation, and maybe 30 throughout internationally. So those are the type of things that we need to help our individuals with brain injury to become more productive, and then also to help our caregivers, help them with the resources that they may need, and help them with a little bit of respite that they have. I'm also the president of the Brain Injury Association of Virginia, and we have a camp called Camp Bruce McCoy. And at that camp, we've had it for many years, and we allow people with brain injury to go and be at the camp for 2 weeks. That gives the caregivers a little bit of a respite too. So these are things that are not as just some great ideas that maybe we could do and try to get more of these resources so that we can more help our caregivers be better off and be more to be able to deal with brain injury a little bit better.
Thank you, Kelly, for talking about
your personal as well as professional journey over many years. We will now hear from Liz Rotenberry.
Hi, good afternoon. Thank you so much for having me here today. I am Liz Rotenberry. I am the Fellows Program Manager for the Elizabeth Dole Foundation. I am also an alum fellow for the foundation, as I'm a caregiver to my husband, Chuck Rotenberry, who was injured in Afghanistan. On March 29, 2011, almost 10 years ago now, I received a call from Marine Corps headquarters. They informed me that my husband had been injured, that he had sustained minor physical injuries. A Marine behind him at the time, out on a mission, did step on an IED that blew my husband out 15, 20 feet downhill, losing consciousness. When he came to the aid and rescue of that Marine. And it wasn't until he returned to a FOB several hours later that he realized he had suffered his own injuries, taking shrapnel to the neck and back. Those minor physical injuries would prove to be so much more debilitating than just shrapnel wounds that he received in the physical parts of his body. July 2011, he returned home from that deployment. And at that time, immediately, I knew something was very wrong. This was not the man who I'd sent off to war. This was not the man who loved his children, loved being with them. He could no longer be in the house with us. He could no longer bear to hold his children. And we had just given birth 2 weeks after his deployment to our little one. And so to have a newborn now in the home added to that impact. I didn't understand what was going on. I didn't know what was wrong, but I knew something very serious was happening. I encouraged him to seek treatments, to try to find out, to ask questions. And at the time, there was no recovery care coordinator for us. We didn't get to go to a Walter Reed or a hospital. Nobody informed us or sat us down to say, your husband's now suffered a traumatic brain injury. It was 2011. It was the height of traumatic brain injuries happening to our service members. And yet the biggest talk was in the NFL around traumatic brain injuries. Unfortunately, we went several years. My husband was a promoting gunnery sergeant in the Marine Corps, and all of a sudden he wanted to get out. I knew this was a red flag. Again, going through the civilian process, getting out and not understanding what to do, who to turn to. I was faced in 2013 when my husband shared with me that he would rather take his life than to face the daily burden of putting the burdens on not only myself, but our family and loved ones. Nobody understood the pain he was going through. And so from that moment on, I knew that this was something very serious and we needed to find out what was happening. Fortunately, the VA Caregivers Program at the time, when we enrolled with the VA, shared with me the importance of my husband's injury. They sat me down, told me, your husband suffered traumatic brain injury. He's at the highest level of care, and it's tier 3 because he is he's a mild to moderate traumatic brain injury, but the injuries and the symptoms were so severe that he rated that highest level. What saved him was a SPECT scan image. I paid out of pocket. I had to pay $2,500 in order to get this image. And it was this image that gave somebody who thought they were crazy, thought they were going insane and didn't understand what was wrong with him. It gave him a physical injury. It gave him that visible understanding that it wasn't just him. It was the front left lobe of his brain that was no longer receiving blood supply due to that explosion. I'm here to talk to you today about some of the gaps that not only we experienced during those dark years, but now also what we're doing as a family. The impacts on my children have been so severe that my oldest son was suicidal at times because the impacts of caregiving on him was too much. So I'm here to share with you not only my perspective, my family's perspective, but also what we're doing as a foundation, some of the research, some of the programs we're offering, the opportunities for inclusive care, understanding the importance of that caregiver and having them in the room. So I thank you today for this opportunity to share with you, and I look forward to talking to you.
Thank you, Liz. And we look forward to having many questions from the audience and the committee about the journey that you described. And our last panelist is Anjul Sanders.
Good afternoon, everybody. Thank you to all of my fellow panelists for sharing those stories. So what I'm going to do is provide my perspective as a researcher and a clinician on where the gaps are with regard to assisting families. And I think that a lot of those gaps have already been talked about, but I kind of want to put the research strength behind those to show that there is a gap in research in ways to help family caregivers as well. And if we can fund research that can test what the most effective ways are to assist people, then we can perhaps get insurance companies to pay for some of this care and also disseminate it and get it out there to clinicians who can use it to help family members as well as the people with TBI. So there's been over 5 decades of research that have documented the stress experienced by family caregivers of people with TBI. And the research has consistently demonstrated emotional distress in family caregivers, including depression and anxiety. And family members have been shown to have persistent unmet needs, particularly needs for emotional support and for assistance with everyday activities. As time goes on, they become increasingly socially isolated and left on their own to provide for the needs of the person with TBI, as well as for the rest of their family. While there's no doubt of the negative impact of TBI on family caregivers, intervention programs to assist them remain elusive. Still, when I encounter caregivers in my clinical work or during my research activities, they seldom report any consistent source of assistance or support, particularly if they're beyond 1 year after injury. The research that documents negative impact on family caregivers has not been matched with research funding to develop and systematically disseminate interventions and programs that can assist them. There have been educational materials created to assist caregivers, and there have been some interventions developed to aid them in coping with the caregiving role and in meeting the needs of the person with TBI, as well as their own needs. Some interventions that have shown promise include group education, individual education and stress management training, training in problem solving, and couples interventions. While these programs have shown promise, much more work needs to be done to show their effectiveness for improving caregivers' mental health and quality of life, as well as improving outcomes for the person with injury and at different times after injury. So it's not necessarily the case that one approach will work at all times post-injury. There needs to be attention to that fact. There also appears to be a disconnect between existing research evidence and clinical practice. Educational materials that have been created for family caregivers often don't make it into the hands of those who could benefit, particularly for people who live in underserved regions of the United States and/or in underserved communities. General healthcare practitioners, including mental health therapists and primary care physicians, often serve people with TBI and their caregivers, but may not have the knowledge of their unique needs and how to assist them. The following gaps in knowledge and knowledge translation exist regarding family caregivers to persons with TBI. First, what is the most effective intervention for family caregivers in the acute, post-acute, and chronic stages of recovery from TBI? We already know their needs. It's time to develop and test targeted interventions to improve their health, coping, and quality of life. Second, what are the individual family caregiver characteristics that impact effectiveness of interventions? Potential characteristics include their pre-injury mental health, socioeconomic factors such as education, income, and neighborhood supports, coping styles, and cultural beliefs.
And Anjul,
Yes.
could you wrap it up quickly?
Yes.
Our time is up. Thank
Just
you.
have two more quick points. So third, what naturally existing systems of support can be used to facilitate family caregivers coping with the daily demands of caring for someone with a TBI? And finally, how can existing resources for family caregivers be disseminated widely in ways that make them available to caregivers at their time of need?
Thank you. Thank you all for presenting a variety of perspectives around the family impact and the gaps. And a recurring theme is that there is limited, or in some cases, lack of family training, education, support. And so, could you share with all of us what do you think needs to happen to move that needle for those gaps to be addressed? Some of you had talked about insurance coverage, congressional funding, but what do you think is key now to move the needle to be able to provide more support services for family caregivers and entire families?
Yeah. So in our perspective, one thing that I found, and granted, I'm speaking so from a veteran military perspective, it needs to start from the onset of the injury. Sitting down with a family, you know, for us being a mild to moderate TBI, like I said, we didn't get to go to a medical facility where typically you are handed a little bit more information than what we ever could have received. And so, you know, when they have in his records that he sustained a traumatic brain injury or a concussion or was involved in some form of explosion, it would be nice that the DoD side could sit us down as a family and share with us, you know, here's the injury, here's what's happening. And take a look at your family. I mean, my children, I was fortunate that we had families overcoming under stress, the focus group that was provided on base. I found them, just so happened to find them, and they were able to sit my children down and explain a little bit to the kids about what had just happened to dad. What do you think happened, and kind of work through that therapy. But I think when you see, even in the civilian world, you know, like Dr. Gary, I know you were involved in an automobile accident. You know, what are these red flags that we can then encourage that further deeper communication around what's to expect now, and take TBIs more seriously than just the physical injuries that they're caring for at the time. That's kind of how I see it.
Thank you. Kelly, would you like to add to that? You have to unmute yourself.
Okay. I totally agree with what Liz is saying, and it definitely should start at that point. But then there needs to be a little bit more continuity of care, because when individuals, once they get past the acute stage, it's a lot more. I think I mentioned it when we did the pre-planning. There's a lot more that individuals find out once they get home, once they get back in their environment. And whatever if they were in rehab, whatever they might have learned in rehab might not be as translatable or does not transfer into the home. So the family members might be at a loss for what is truly going on once they are now at home, and it might be totally different if they had received rehab or what have you when they were in a hospital setting, or even if they're like a person with a mild or moderate brain injury, and it's just not as clear. So that continuity of care, what supports can they have starting in the beginning and continue once they get home, and once there's a true reality. The person might look great, they might have recovered extremely well physically, but a lot of people know that with cognition and with emotions, that might be a much longer journey. So looking at them, maybe without them saying anything, everything might look fine. But as soon as they open their mouth, or as soon as something happened that they don't expect, then everything changes. So what do they do now? So how can it be that continuity of care? How can it start in the beginning, and how can something be given once they get post-acute?
And Kelly, you said something very important too, where you said the person can look great, but be struggling in many different areas. And so we often think of TBI as an invisible wound, an invisible injury. And so I'd like you all to think about the emotion work that I've heard caregivers describe, that in addition to assisting a loved one with activities or medications or going to health visits, that there's a lot of emotion work in the caregiver role in terms of controlling or managing your own emotion as a caregiver, as well as trying to manage the emotions of your loved one. Could you talk about that? Anyone among the panelists?
So just to be clear, you're asking about the emotions of the caregiver
Both.
and the impact.
Your emotion work, yes, because you are doing a lot to manage your own emotional adjustment as well as the emotions of your husband.
Yes, I know as a caregiver, and Susan, I know you unmuted. If you'd like to chime in, I can let you go ahead if you'd like.
Well, I was just going to say that I've been told by family members that it's at night when they are most afraid, because they don't know what to expect. And for an organization like the Brain Injury Association, it's very frustrating that we have developed materials. We've developed materials for the acute end, for the post-acute end, for how to talk to your children. And we just don't have enough resources to get them out there. And we're not the only organization. There are other organizations that provide information for families. And I think the issue is that the injury is so devastating. It just absolutely turns your whole world upside down. And there's so little time. You know, people, a moderate brain injury, and they're in the medical surgical ward for 3 to 5 days, and then they're kicked out. And if they're lucky, they get to go to an inpatient rehabilitation facility. But that has, you know, the time there has digressed to about 2 weeks. And that's not enough time. Honestly, that's not enough time to prepare either the patient who's been injured or the family member with all of the stuff that they're going to have to cope with. And so the emotion that is felt is fear. It's absolutely fear. And especially because they don't have their partner often to share it with.
Yeah, and I'd add to that as well. I mean, Susan, you hit the nail on the head with, I've had so many breakdowns in the middle of the night, and it is the quiet of the night where, you know, my husband has even said it's the silence that can kill him the most, because that's when you start facing your fears and you realize the amount of stress you're actually doing daily, that it overtakes you. And so, you know I've reached out to so many crisis lines in the middle of the night, and it can be a struggle. Some of them, you have to wait a week to get a return call. Some of them can't give you service because you're not the veteran. And so I know that the VA caregivers line now has a crisis line, which is helpful, but we do need to be doing more for caregivers, for their families, finding them resources. For my children, I was fortunate to find a military child post-traumatic stress therapy unit offered at Kennedy Krieger. But this is only one of, in one location. Why do we not have these set up for these families all over the nation? It does make an impact, because it's not just me facing these burdens, but it is very stressful when, your husband returns home from deployment and you're expecting him to be that husband, be the man of the house, take on those responsibilities, and he no longer can do it anymore. I still manage the bills. I still cut the grass. I still do everything around the house, manage all of the kids' appointments. And it's debilitating on me as well. But you don't have a choice as a caregiver. You have to keep pushing forward.
Anjul, would you like to add to that based on your research that touches on the issues that Liz and Susan and Kelly have described?
Sure, and I do want to mention that that Liz referred to the crisis lines that she called. And it's wonderful that they have those services available, obviously not as much as they should, but there's not anything that I know of on the civilian side for caregivers. It probably varies by state. But in Texas, we don't have a line like that. So there's not a place for caregivers to call, unless they're suicidal, and then they can call a suicide crisis line, but there's no TBI specific crisis line. A universal crisis line like that would be wonderful for caregivers as a resource. And a while ago, Helene, you asked the question about what one thing could be done. And I see that Monica also is saying, can we speak to the most important supports that caregivers should receive in week 1? I think that the greatest support for caregivers on the acute side is to provide them with future resources that they can access. And so, because their needs are going to change. And so whatever you can do to help them in that one moment, 5 weeks, 10 weeks down the road, they may not remember that. They're pretty stressed at that time, when they're in acute care. But if they have resources that they can access when they need them, then that's important. In my opinion, the number one thing that could be done is that every single caregiver to a person with TBI is hooked up with a case manager initially, and that person follows them out at regular intervals, so that as things change and evolve over time, they can be referred to resources that would help them for whatever their needs are in that moment.
So I just want to, 2 things I want to say. Yes, I agree. A case manager is great as long as the case manager has a low enough case level that they can actually pay attention to someone. I mentioned earlier, it would be great if they were paid on the patient or family satisfaction instead of by the payers. The other thing is there is a nationwide number, 1-800-444-6443, 1-800-444-6443. It doesn't run at night, doesn't run in the middle of the night. I wish it did. But it will connect you to a TBI specialist in your state. And if there isn't a TBI specialist to answer our National Brain Injury Information Center, you'll get the BIAA main office, and we will connect you. We will hook you up with resources in your state. So there is an 800 number. It's not 24/7 because we don't have the resources for it, but it is out there.
So one recurring theme we're also hearing is that there are some resources out there in the community, but not everyone is aware of how to learn about them and how to access them. So we now have time for our committee members to raise questions of the panelists. And we'll start with Jeffrey Manley.
Hi, gang. I know many of the panelists well, and great to see you. And thank you for taking the time to speak with us today. So, Susan, you mentioned this rapidly contracting short stays for rehab. And, I think on one hand, we're learning so much about the neurobiology of brain injury and recovery. And, it seems that there's a mismatch now between what we know about what's required for the biology of recovery and then these hyper short rehab stays. What's really the cause of all this? Why has all this been contracting? Can you really help to educate us on what you've seen? Because I know you've been in this field for a long time and really just constantly struggling to raise awareness of TBI and raise funds for advocacy, which, as you know, has been super challenging. Thanks.
Hi, Dr. Manley. Nice to hear your voice. I really, I hate to be a broken record, but I really do blame the payers. To be honest, United Healthcare is, they're trying to make money. And so the higher the premium and the fewer the payout, the more money they make. It's it's sort of a supply and demand kind of thing. And the truth is that unlike something like pregnant women who are, legally allowed to stay in the hospital 2 nights, there's no minimum standard of care for people with brain injury. And the folks who are writing the guidelines, Milliman and people like that, it's all a regression to the mean. It's the lowest common denominator that they can get away with.
So I'd like to follow on with that because, in the first panel, Scott Hamilton, who was a patient of mine, talked about, the lengths that he had to go to get Blue Cross Blue Shield of California to cover them. And, what they were saying is that, one, they didn't think that rehabilitation worked. And number two, that he didn't meet this 3-hour rule. And I find as a physician that not meeting this 3-hour rule, I mean, what is this 3-hour rule that they're talking about? Because I think, some people have written opinion pieces that it may be discriminating against people with traumatic brain injury.
Dr. Manley, I can speak to that. Working in inpatient rehab, that 3-hour rule is that they need to be able to have, enough energy and endurance to be able to have at least occupational speech or physical therapy for at least 3 hours a day, 5 days a week, for that reimbursement. And either they are at a point where they might be so severe that they're not able to do that, or they might be at the point where they have a higher, they are at a higher functioning point, but yet they still have those issues with a brain injury that's unique to brain injury, that they'll be able to max out of that, but still have the issues with brain injury still. And it still is a major problem. And then they get sent home because they're able to do the basic things like bathing, dressing, feeding, all those things, and they max out of inpatient rehab, and then they sent home and they still have all of these intricate issues with their cognition.
Just quickly, the short answer is it's controlled by Medicare, and you are designated as an inpatient rehabilitation facility if you care for patients who have one of 14 conditions. And one of the conditions to be caring for a TBI patient is to be able to have 3 hours per day and a 5 out of 7 day week of intensive therapy, OTPT speech, but they don't count other things that could very easily count as skilled therapies. For example, psychological counseling. So it's that we've really taken the discretion away from the physician where it should be, to decide what's in the best interest of the patients. And
Thank you.
I can get you more information on it if you want.
Thanks.
And I think it's also, I think it's also an issue that early on people go to inpatient rehabilitation, usually straight from the acute trauma center. And most of the focus is on physical occupational therapy and speech therapy to help with some of the, basic communication and memory issues. But many people actually max out their benefits at that point. And so then when they are home, they have problems and they don't have any insurance funds to help with those. In many cases, people need to go to inpatient rehab, but I think that's also just the natural flow of things. And people often don't question, might these benefits be used more effectively down the line? So that's another issue, that that decisions are often made just because this is what we typically do, and not enough attention is paid to actually what the person's long-term needs are.
Thank you. We now have a question from Eric Schumacher.
Thanks. Thanks very much, Wayne. 2 real quick questions, and then I'd just like to ask Liz a little deeper one. Is it okay if we call you by your first names? Is that acceptable? Good. So Kelly, my name is Eric Schoonmaker. I have a military background. I'm a former Army Surgeon General. Kelly, just to clarify, was your injury while you were in the ROTC in a non-military setting, and then you attempted to go into your officer training. Is that correct?
Yes, I was in the U.S. Army Reserve. I had served 1 year, the split training program. So I had done basic training, and I was in the year where I had just did 1 year of ROTC when I came back from basic training. And I had not yet finished my AIT, so I did not have my full time in. So it was,
And your injury was in your civilian life, is that
yes,
correct?
yes, it was.
Yeah, and that tracks with what we observe in the military. Is about 3/4 of the TBIs in the military actually occur before someone enters the military while they're in civilian life. And then Liz, your husband, I'm very thankful that the panel was so candid about all of their observations. We're very sorry to hear about your husband's injury. You know, we've found in the military and the VA that probably over half of people who've had an injury that results in any degree of chronic pain also have TBI and post-traumatic stress. There's a tremendous comorbidity complex there. And with some very good data that supports that TBI and post-traumatic stress have many, many shared symptoms and signs. Despite the fact that your husband was not identified as having a TBI at the point of his injury, was he at least evaluated for post-traumatic stress? Was the man who, for example, the Marine that was stepped on the IED, was he killed in the prospect of that, or in the action of that?
No, he was not killed. He did suffer double leg amputation.
So
Yeah,
so
and
grievous wounds all around him, and that's a very common thing. I think your husband also illustrates something that we learned, and ironically, just about the time he was injured, that if you allow soldiers and Marines and others to determine themselves whether they've had a TBI, they'll always defer to going back to work in the unit. I mean, we after the fact have met Marines have had 40 TBIs before they admit to the fact that they're suffering from these. So, you know, the best protocols we think are the ones that say you don't have a choice in the matter. You were blown up, you were knocked unconscious. You don't get to decide. It's like a football player, or or a soccer player or a hockey player. You don't go back in the game. You step aside. I mean, imagine if you're in an airplane and you see the pilot walk up the steps and he falls down and he knocks himself out and he's lying on the tarmac and he wakes up and he gets up. Would you let him go up into the cockpit and fly the airplane now? Heck no. And yet that's kind of still the culture that we have. So thank you very much. And I'm very sorry for his injury.
And to
Yes.
build on what Eric had just mentioned, Liz, you had reported that he wasn't the same man, that he couldn't be in the house, that he couldn't hold your child. And so during that time, were you receiving any support from the VA, from family, friends, the Dole Foundation? What was happening in terms of supports for you at that time?
So this was again back in 2011. It was the height of the Afghanistan war. There was a lot happening in the military. And at the time, I was not aware of the Elizabeth Dole Foundation. They actually didn't come about until 2012. And I didn't actually learn about them until 2014. But at that time, this is why I'm so concerned, is that it's the mild to moderate that are lost. Like I said, we don't get the opportunity to sit down with any physicians. Eric, I appreciate you saying what you did, because yeah, my husband is a proud Marine and he loved being with his unit and he would serve any day with them. And what was concerning to me was when he came home in July and told me that he wanted to get out of the Marine Corps, he honorably discharged, did not med board, which he should have med board as well, that this was happening. I mean, and he saw himself failing. He saw himself becoming, experiencing memory loss, debilitating migraines that he couldn't even show up for duty, speech impediments, couldn't put thoughts together. I mean, we were going through so many different trial and errors of medications that it became just this dark process of trying to figure out what can we do to treat this next symptom that's popping up. What can we do?
Yeah, I'm sorry, Liz, please.
No, that's okay. It just became a trial and error for us. And I mean, fortunately for my husband, I am an advocate. I am a go-getter. I'm a pusher. And not a lot of families have that opportunity. Not a lot of Marines and soldiers have opportunities for a loved one to be by their side to help them. And that's why that caregiver role is so important.
Well-
Having somebody. Go ahead, Eric.
Yeah, and I think Helene's point is also, even with those symptoms, which are many of which are the symptoms of post-traumatic stress, someone should have been paying attention. Part of the problem with, and I don't think this is restricted to the military, is you made a point, until he could see a defect on a SPECT scan, he did not think he had an injury. And many of the injuries associated with TBI and certainly with post-traumatic stress don't have a physical injury associated with them. And they're not comfortable thinking of themselves as being damaged in a domain that is not, their arm, their leg, or their back, or something else. So thanks very much. I appreciate the time.
Thank you. We have a question from Jennifer Bogner.
Thanks. I'm Jenny Bogner. I'm a professor at Ohio State and a traumatic brain injury researcher. Some of the comments that were made in this panel made me think about the fact that, we've often concentrated much so far on the medical model and that early care from acute care to inpatient rehab. But what about living with a traumatic brain injury? Where are the things, what are the things that we're doing well, and where are our gaps? If the panel could speak a little bit to that, that would be great. Maybe Susan, Anjul?
Yeah, so I would love to see more home and community-based services and supports. I'd love to see more funding for that through states. Kelly talked about clubhouses, and I saw an earlier session where there was no mention of support groups. There are support groups all over the country, but many of them are affiliated with the State Brain Injury Association or State Brain Injury Organization, but they are out there. There's also camps and the things that Kelly had already talked about. There is training for families. There is support available for family. It's costly and hard to get. That's really the challenge. But it is there, and there has been a lot of work done in terms of what really helps the transition. And we could also talk about transition from the hospital back to school. And from the hospital back to jobs, and the hospital back to former social roles. There is a lot of information out there. It's just difficult to access because nobody can pay for it. That's the problem, in my opinion.
Kelly, you went through some of this when you were, it sounded like when you were going through your initial transitions. Where were the biggest gaps?
Well, I think for me, some of the gaps came because I was at that point where I was in college and not yet an adult. So I didn't have an IEP to help out with supports that way because I wasn't in high school. And then that back then, and that was even back in 1990 when it occurred. So there was even less, out there. But there was definitely something for children, and there was definitely, maybe something for older adults. But I was like right in the middle, and I was unique in the fact that my injury was really severe, but I didn't have a lot of like broken bones. I didn't have any broken bones. It was all neurological, and I guess because I was extremely healthy and I had been in the military, that I healed physically really well. But the cognitive piece, the emotional piece, that was, it took years. And I even have issues to this day. It's been 30 years. But that was really the point with me. And so when I thought, with lack of insight and impulsivity, I thought I could just, after getting out of outpatient rehab, I thought I could just go back to school and do everything that I used to do. Get back in ROTC, back to my reserve unit and everything. And I went down to school and because I wouldn't take no for an answer, and flunked, totally failed at everything and had to, go back home.
Really having those disability services. Susan?
Yeah, it just, you know what, we used to harp on this all the time. The truth is that there are existing systems. There's a vocational rehab system. There's a mental health system. There's a aging and disabled system. There are all kinds of systems. And rather than totally reinvent the wheel, if we could do a better job infiltrating those systems, training those existing counselors, providing them the information, we would, more like an octopus, the tentacles of an octopus, reach out much faster than we could possibly do it just, based on individual care coordinators or individual resource facilitators, which is what we have in the private sector.
Right.
A couple other questions since our time is limited. Frederick Kofi Corley, you had a question or comment?
Sure. Hi, thank you so much. And thank you to all the panelists. Really appreciate your time and sharing these personal stories and insights. One message has come pretty clear to me throughout all these sessions, which is that we're not doing a very good job with educating our patients about our injuries. And based on some of the work that has been done by some of us, including Dr. Manley, we've discovered new blood tests for detecting brain injury. And some of these tests can tell you how badly the brain has been injured, but they're not always as good with telling you how well a person is going to recover. Because even if you've had significant brain injury, some people do well, others do not. And many factors affects a person's recovery. So when these tests become available for use in a hospital, do you think that sharing information about these test results, will be useful to patients and families? Or is there a chance that, some people who, have a lot of brain injury based on the blood tests, may perhaps lose hope because, the injury seems, very significant from the blood work. And I'm talking mainly about those with the so-called mild traumatic brain injury.
I know for me personally, it would have saved me years of being lost, not knowing how to help my husband, not knowing what to do for him. Like I said, that SPECT image that I paid for back in 2014, I believe it was, that was now 3 years after his injury. Those 3 years, we really struggled. So anything you could do to provide that immediate information to the patient, to their loved ones, will be life-changing. I would have done more research a lot sooner, and we'd be in a better place ahead of time. But it fluctuates, of course, with traumatic brain injuries. But once I know, I'm able to then do the research to get the care.
Yeah.
I think that everyone's injuries are different. One thing with mild injury, and Liz, I think I would question, based on what you've described about your husband, if he had a mild injury. It sounds like his injury was probably moderate to severe. It's hard to know when people are, in theater at the time of injury, what their severity is. With injuries that are clearly mild, based on duration of unconsciousness, post-traumatic amnesia, a variety of measures that we use to assess them, there could potentially be a danger in using a biomarker test and telling someone that they have an injury, because we do see with an uncomplicated mild TBI that many people recover within 6 months. And that, so, it's an interesting question. If you tell someone that they're going to have problems, if you then, have them experience problems. There's probably not a clear answer, yes or no, about whether you want to give people biomarker information, because you could have an injury based on a biomarker that doesn't have clinical manifestations.
Anjul, I'm sorry, these are all very, very important points, but I first wanted to ask Kate if we have any questions from the audience, because we're very tight with time.
Nope, I think we may have to wrap up this panel, but no, we don't have anything from the audience.
Okay. So I certainly have to thank Liz and Susan, Anjul, and Kelly for sharing their personal journeys, for Liz and her family, Kelly and her family, and then here over many, many years, what are some of the major problems, gaps in TBI care and support of families, and what are the challenges for us in terms of insurance coverage, congressional funding for services, and looking at patients and families in the long term, looking at this as a long-term trajectory, and what are the services that people need along that journey. And we're also hearing from this group that advocacy, that family members are advocates for their loved ones with TBI, and they also need support and tools to be better equipped to be the advocates. And so I certainly want to thank you all. And Liz, I hope that your family, your children who had also experienced the impact of TBI, I hope that they are all doing better, as well as your family. And I commend you for being Elizabeth Dole Fellow, because you're reaching out and really working to help other families, military families struggling with TBI. And also Kelly, to see your progression from a severe TBI to now an OT who is doing work around racial ethnic disparities is just amazing. So I commend you all for your extraordinary work over many years. And I'm sorry that our time is up.
Thank you so much, panelists, and Helene, thank you for getting us through a very, very rich conversation. I see Monica Vavala and Martin Schreiber had questions. Could you, let me give you a chance to state your question. You won't get the answer, but the question will be on the record, and our panelists maybe want to text in or email their answers.
Sure. Thank you so much. Thank you for sharing your insights with us. My question it pertains to this. So what if we were to ask, what would be the top 1 to 3 pieces of information or supports that we should provide caregivers in the acute phase of treatment? What would that be?
Thanks. And Martin?
Hi, it's Marty Schreiber here. I'm Chief of Trauma at OHSU and a reservist in the Army that's been deployed. My question really relates to your thoughts about how could we do some of the functions that we're asking rehab to do, and how can we teach the families to really take on some of these factors that could do this for the long time and start early. We're stuck with this rehab period of optimal time period. What about before and after? What can we do to get the family involved to really help with the rehab? Is that even feasible? Thank you.
Great questions. Panelists, may I ask you as a favor, if you would email in your answers to those 2 questions, 1 to 3 pieces of information you think are essential to give to families and caregivers in the early phases, and elements of rehab that could be moved to families and through skill building and other techniques. That would be very helpful. Thank you again, panelists. I wish we had double the time to stick with these panels. They're just amazing.